Good evening, everyone. I'd like to call to order the February 10th, 2021 Program and Budget Committee of the Community Mental Health Board, and we will start by a board member roll call.
Lori Phillips, 45215 Plum Grove, Macomb, Michigan, board member.
Ncqa remotely from Roseville, Michigan, Macomb County.
Selena
I was going to have
Schmidt.
Sandy go through.
It probably would be easy, Phil.
We're all eager.
I'll call out first names. Selena,
Selena Schmidt from Shelby Township, Michigan, Macomb County.
Brian,
Ryan
Randy
Fantuzzi.
Govan, Macomb Township.
sorry,
Remotely.
Brian.
Ryan with a B. Got it.
I have to be clear. Ryan,
Ryan Fantuzzi from the Village of Romeo, appearing remotely.
Chris,
Chris O'Connell, participating remotely from Washington Township, Michigan, Macomb County.
Megan,
Megan Burke from Chesterfield Township, Michigan, Macomb County, remotely.
Linda,
Linda Bush, remote from Harrison Township in Macomb County, Michigan.
Dana,
Hi guys, Dana Frears appearing remotely from Clinton Township, Macomb County, Michigan.
Kathy,
Kathy Votsberg from Chesterfield Township in Macomb County, Michigan.
Phil,
Phil Kraft attending remotely from Chesterfield Township, Macomb County, Michigan.
Tony,
He's muted. Tony, you're muted.
Thank you. Am I in now?
yes.
Anthony Plua from Shelby Township, Michigan, attending remotely.
All right. If I missed anybody who didn't speak up before I started that, please speak up now. That, I think we're good.
Thank you, Dave. Next time we'll hold up flashcards so we know if it's Brian or Ryan. Next up, I will read the mission statement. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence. I'll take a motion for adoption of the agenda.
So move, Nick.
Support Schmidt.
Motion from Nick, support from Selena. Any questions or comments? All right, seeing and hearing none, all in favor signify by saying aye.
Aye.
All opposed? The agenda is adopted. Next is hearing of the public. Anybody from the public wishing to speak on any item on the agenda? You have 5 minutes. Give us your name and address. Calling hearing of the public once. Hearing of the public going twice. Don't forget to unmute yourself. Hearing of the public third and final time. All right, hearing and seeing none, we will close hearing of the public. There is also another opportunity before the end of the meeting. We will move on to item 5A, a request to approve request for proposal consulting services for Ncqa Mbho accreditation and readiness assessment. I'll take a motion.
Approve Bush.
Support Burke.
Motion from Linda, support from Megan. Dave, did you want to speak to this?
Yes, briefly, it's it will allow us to issue a request for proposal. The Ncqa is is a form of accreditation. It's kind of a step up. I would describe it as from our current accreditation, which is CARP. Mbho is a managed behavioral health organization. And these the consulting services will come out, work with us, help us complete a readiness assessment, and then we'll be able to report back to the board about where we are, where we need to focus some efforts, timelines for the actual accreditation, process and things like that. So it's just so
I
we
have a
can issue
question,
that.
Phil.
Go ahead, Linda.
So does this mean we won't do CARF anymore, or we'll do both?
Once we're accredited through NCQA, I would recommend that we let the CARF lapse. Although we could keep CARF on the CMHSP side for these services and keep NCQA on the PIHP side for the oversight.
Dave?
Yeah.
What's the downside for having both?
It's just more audits, more paperwork, more tracking, and more money.
More bureaucracy. Got it.
Cost for the accreditation.
I just want to say, I don't work in the field day to day or haven't been that involved, but I always thought CARF was the recognized accreditation for county community mental health. So that's changed. This new one is, you say that it's a step up, that it's.
NCQA is what the Medicaid health plans are accredited with. It allows us to more easily work with them and to share information. There's the HEDIS measures, as an example, are standardized, nationally standardized outcome measures. When you subcontract or delegate responsibilities, you get like automatic credit, you get deemed status if you delegate to an entity that's already accredited through NCQA. So it allows us to work easier through integrated health efforts like our CCBHC and things like that. Our folks from the hospitals and health systems, I'm sure, are very familiar with the NCQA process.
If I can, Bill?
Yep, go ahead, Nick.
Dave, if this is just to enter into the contract to prepare us for certification and to get certification, the decision as to whether or not we want to drop CARF is later. We don't have to make that decision now.
True. Yes. We just got a 3-year accreditation on CARF, so we're good.
Thank you. Any other questions or comments for Dave? All right, seeing and hearing none, we have a motion and support. All in favor signify by saying aye.
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 All opposed? Motion passes. Next is item 5B, request to approve, request to issue contracts for outpatient substance use disorder treatment. Take a motion to approve.
So moved, O'Connell.
Motion to
Support.
support
Van
Phillips.
Dusen.
Motion from Chris. I think I heard a tie between Lori and Ryan.
Lori can have it.
We'll give it to Lori. Dave, is this you or is this Helen or both?
Yeah, it's Helen. I'll let her speak to the details of this. So we did issue an RFP. Those were reviewed and Helen has the result.
Thank you. The information is in your packet and I'm sure you've already had a chance to review it, but we issued our request for outpatient and intensive outpatient treatment services. We did receive 6 respondents. Going through the review process though, it is noted that one of the applicants did not have the appropriate accreditation that's required to contract for that level of service. So they, in the end, weren't considered eligible for contracting. So of the others, our review committee felt pretty strongly that they had good proposals, that they meet at least the minimum, if not exceeding some of the requirements that we have. So we are proposing contracting with Judson Center and Easter Seals, which you might be familiar with, as mental health providers, but they would be new to the substance use services. Access, the Arab Community Center for Economic and Social Services. They do mental health services currently under contract with MCCMH and prevention services for substance use. But this would be doing outpatient substance use care for us now, as well as 2 of our current providers, CARE, which many of you have approved many times before for peer recovery and prevention type services, as well as Share Macomb, who currently does residential services for us. So they'd like to expand their contracting to include outpatient care. So these are the 5 contract proposals we received that we would request approval for. It did go before the Substance Use Oversight Policy Board at the beginning of the month, and they approved and are recommending these to this board here.
Question.
Thanks, Helen. Go ahead, Nick. And then
Helen,
Ryan.
so Helen, you're the, I guess I misread the write-up. You're actually proposing all 5, right?
Correct.
Or
Yes.
one element or another. Can you explain the scoring issue? It doesn't say out of what. So I don't know, is that 41 out of 50 or 41 out of 1,000 or?
Sure. So sorry for leaving that off for you. The overall score, there were 11 elements for the overall organizational experience, and they could be scored from 0 to 5. And then for the actual services of outpatient and or IOP, there were 13 elements each there. Again, a score of 0 to 5. So these are the 2 totals for those areas.
Oh, I see. So you're adding them all. So when you get 41.
41 is the first half. It would just be your organizational experience, having accreditation, a proper license. So basically saying your organization is appropriate. And then as it relates to the other score of outpatient and IOP, that would be specific to those services that we want to contract with. How did you score out of 13 questions?
Yeah, I guess I don't understand what the maximum score is. And
so,
maybe more important, don't figure it out. That's okay. I assume you and the advisory committee did that, but
yes.
Does the advisory committee and the staff have a minimum score that they're looking at in each of these categories? I mean, there are 2 that are NA, but I assume Kara and Cher Macomb aren't dealing with IOP, so it doesn't make.
Right, so they didn't write for that service line. So that's why there's no score there. Yes, they did, everybody did meet the minimum requirement here. So we would look to see that everybody had at least an average of 2.5 on their scoring overall. And so that would, out of 1155, so yeah, we had everybody meeting the minimum here.
Okay.
And usually the total line is on there for you with a possible score. It just got left off this time.
That's okay. I just wanted to make sure that that there was a minimum score, that you weren't just listing what their scores were.
Yeah.
Thank you.
Mm-hmm.
Thanks, Nick. Ryan, did you have a question?
Yes, I did. To build on Nick. So with Beaumont, Helen, why do they not have accreditation? And I guess how long of a process is it to have accreditation? And you know, how important is accreditation?
So accreditation is required to use any of our federal money, our Medicaid funds, or our block grant dollars. So it's absolutely required for this type of service. Beaumont is one of our opiate health home partners, but as that, the accreditation wasn't needed for that type of service, but for the treatment services, it is a requirement through our state contract. So when they submitted the proposal, it is spelled out in the RFP that we issued that it was required. They have accreditation as a hospital. And so they misunderstood, thinking that that accreditation would make them eligible for this. But we spell out that you have to be accredited for the service that you're proposing. So you may be accredited for CARF like we are for outpatient care, but maybe you're not CARF accredited to do like a residential treatment service. So even though you have accreditation, it has to be accredited for the service you're proposing to provide.
Is it possible for them to cure this accreditation, or is that a really long process? I mean, how long are these contracts for? Could they apply again next year?
So it is quite a process to get this. They only opened their outpatient clinic, I think in last year, September. So you need at least, you need a caseload, and you have to have that. I believe it's about 6 months, for example, with CARF, and there might be other requirements depending on which accreditation body you're going through, because there's 5 that the state recognizes. but they weren't ready at this point or even in the process of applying yet for that accreditation. So they are eligible to apply again next time we issue an RFP or, when we feel the need for additional providers. So they're not like banned forever or anything. It's just until they can meet that element.
And the fact that we are giving contracts to 5 of everyone that's eligible, how are we going to use all different services? How are we going to, why do we need 5 contracts? Why not just use 1?
So the whole reason for issuing the contracts is that at an outpatient level, many times we have difficulty getting somebody in timely. I mean, ideally, we'd like to get somebody in at the time that they request a service or within a day or two. And we've been running into problems with, especially during COVID, it seems that there's been less staff available, and a lot of our providers have been losing some of their therapists through this whole process. So we just don't have very many appointment slots available. So as people propose the services, some only propose to do small volume for us because they have other services that they do as well. And so by having all of them, the thought here was, even if some aren't doing as many clients for us, it will give a lot of different access points in our county for people to get services. And some might have a little more special niche population that they're working with. And so that would afford those individuals an opportunity to get services at that type of provider.
Thank you. That sounds great. Thank you.
Thank you.
Thanks, Ryan. Any other board members with questions or comments for Helen? All right. Seeing and hearing none, we have a motion and support. All in favor signify by saying aye.
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 All opposed? Motion passes. Next up is item 5C, request to approve Molina Healthcare Amendment to Client Services Agreement, new rates. I'll take a motion to approve.
So moved.
So moved.
Jane Tuzzi.
Motion
Support
from
Bush.
Ryan, support from Linda. Dave, go ahead.
Yeah, this is more just like a housekeeping item. We did get the amendment. Our finance folks did review it, look at the new proposed rates. Legal went through the language of it, so it's pretty cut and dry.
Thanks, Dave. Any questions or comments? All right, pretty cut and dry. We have a motion and support. All in favor signify by saying aye.
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 All opposed? Motion passes. Next up is item 6, receive and file. We don't have any items to receive and file. On to number 7, resolutions for Amy. I'm going to mess up this last name, Fallabout, for 30 years of service. Cindy's laughing at me. She knows I screwed it up. I'll take a motion to approve this resolution.
So
So
moved.
moved. Burke.
Motion from Nick, support from Megan. Comments or questions? All right, seeing and hearing none. All in favor signify by saying aye.
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 All opposed? Resolution is approved. Next up is other possible agenda items. We'll go to 8A, Quality Department presentation. I'll take a motion to receive and file the presentation.
I
moved,
thought we were
Schmidt.
having
We will.
support.
All right, motion from Selena, support from Linda. Linda, you had a quick question?
I thought we were having the presentation.
Yes, we are. I'm just
Yeah.
getting
Oh,
motion
okay.
before we start
Okay.
rolling.
Okay.
Dave, you want to kick it off, or should I just hand it over to Cindy?
Yeah, we're very well represented this evening from our quality department. So Cindy, would you like to introduce your team?
You're on mute, Cindy.
You're on mute, Cindy.
Okay. We'll start out with the incident report process presentation, and Laura Duncan and Vincenza Randazzo are the 2 members from the quality department that are responsible to make sure that we track and trend those, and they go to the state for mandatory reporting. And then part of the presentation will also be what we do with those. One thing before Laura starts, I want everyone to keep in mind, you did see the incident reports aggregated from last year. And just because one provider might have a lot more incident reports does not reflect disfavorably on them. It's dependent on the population, on the services that they provide, on us asking them to please, whenever there is an incident, anything out of the ordinary, report that to us. And also if someone has an incident from one day and it's the next day and the next day and the next day, such as they don't want to take their medications, that's their right. They don't have to take their medications, but the group home has to report that to us. So I'm going to hand this over to Laura Duncan, and she's going to do the presentation for you.
Good evening. As Cindy had mentioned, I'm Laura Duncan. I work as a quality coordinator for the quality department. So basically, I'm just going to give you a brief introduction of our incident report processes and what we do with those. And if you have any questions, if you could please hold those to the end, as I may very well go through those in the presentation. All right. Incident reporting. Consistent reporting is essential to allow tracking and trending of incident reports. Continuous reporting of incidents allows us to track and trend the occurrences of incidents through our organization. Therefore, received and reviewed reports allows our organization to identify needs on an individual and systemic basis, which allows improvement of care to all of our persons served. The definition of an incident report, there's two types of incidents that MCCMH tracks, which are critical incidents and risk events. Critical incident is an unexpected occurrence involving death or serious physical or psychological injury. A risk event is an event that puts an individual at risk of harm. And I will go over the types of incidents on the next slide. So overall, we do track and trend for both critical and risk. The number of incidents does vary for several reasons from our providers. It could be, different populations that we're serving, an individual themselves. If, there's a change in staff, we might see more behavioral instances, level of care, different service lines such as outpatient, skill building, CLS, respite, and ABA, as well as other service lines that we do serve. Critical incidents are reported to the state, whereas risk events are not. Okay, so these are the different types of incidents. I'm not going to go through all of them, but these are examples of both critical incidents and risk events that we do track and trend. So if an individual is on a waiver under certain risk events, it actually will fall into a critical event where we will report that to the state, and then it becomes a critical incident. Waivers include the child waiver, the SED waiver, the HAB waiver, as well as children on the autism waiver benefit. So as you can see, if somebody is not on a waiver under a risk event for, they get hospitalized for, a surgery or a medical hospitalization, that goes under a risk event. If they are on a waiver, then it becomes a critical event. However, all deaths are critical events. So the process of the incident report. Once an incident occurs, an incident report must be completed by the witness or the witnesses. It is then sent to the primary case management agency, Office of Recipient Rights, within 24 hours from the occurrence of the incident. The Office of Recipient Rights does forward all incident reports to quality, as then it is reviewed by Office of Recipient Rights, quality, and the primary case management agency for concerns related to rights violations and quality and clinical concerns. Quality does a follow-up. We track and trend all risk and critical events as mentioned. If the incident is deemed to need a root cause analysis, Our quality team will request the case management agency to complete that RCA and work, with the service line if it's, a group home or it happened at skill building within 90 days. It also may prompt an audit depending on the severity of the incident. So if we see something that's, recurring in a group home, we will definitely prompt a full audit on that home. And then upon the receipt of the RCA, it is then forwarded to the CRMC, which is our Critical Risk Management Committee, for review and next action steps. This is a little bit about the Critical Risk Management Committee. Our CRMC is made up of a multidisciplinary team, including our medical director, Dr. Serpa, Chief of Clinical Services, Agnes Ward, Chief of Quality, Cindy, and Director of Rights, Mark Mitchell, along with usually a representative from Network Operations or Christina. Also made up of social workers and an RN. The committee meets on a monthly basis, typically, or more frequently if needed, if we're requesting a lot of root cause analysis and that. The committee is responsible for reviewing mortality deaths, deaths in general, root cause analysis, and critical incidents. And last slide. So in conclusion, it is important for providers to fill out incident reports when identified, mostly to protect, person served rights and that the quality of care is delivered to the people we serve. This will allow positive change to our system where identified. It is also important to note that at any given time, a provider may have more incident reports due to circumstances related to the individual or service lines that we provide, as Cindy had mentioned. And that is it. Thank you.
Thanks, Laura. Do any board members have any questions for Laura before we move on to the next presentation? All right, hearing and seeing none. Thank you, Laura. Nice job.
Okay, the next presentation will be by Ambrosia Jackson. Ambrosia is also a quality coordinator for the quality department, and she develops, monitors, tracks, and comes up with remedial action for the satisfaction surveys that we do through the quality department. So I'll leave it to Ambrosia to do the presentation. Thanks.
Okay, good evening, everyone. So here is the person served satisfaction surveys. I'm going to try to make this big and maybe I'll be unsuccessful. Let's see here. We'll just keep it like this so I don't make a mistake. So when it comes to the person served satisfaction surveys, we had some process changes this year for fiscal year 19 and 20. And those process changes were birthed, I would say, predominantly from COVID and us wanting to increase the quality of results that we got. So what we did is we expanded accessibility through our methodology. Traditionally, we had color-coded materials that we would deliver to each provider so that we know where the results came from and we can calculate we can calculate for each provider and provide them with that information. And what we did this year, this fiscal year, is we moved to an expanded methodology, which included we were able to email persons the survey. We had paper copies available, whether individuals desired for those to be mailed to them, or if they were participating in in-office surveys, they were able to pick those up from there, and also phone calls. So these changes were made to this fiscal year, and part of the reason why is because some of the information that we received back to some of our higher auditing bodies like HSAG and CARF were that we continuously got exceptional results from for our consumer person served satisfaction surveys. So what they encouraged us to do is change some of the questions, kind of give people tougher questions so that with the possibility we can yield different results. So to encapsulate some of the information in fiscal year 18-19, and traditionally speaking, we have gotten 155 responses back with that color-coded method that we sent out with the paper copies. And here's a breakdown of the demographics of males and females of the responses we got. So just changing the way we offer the accessibility to the surveys, we can see the drastic change. We got over 1,000 responses this year. And there again, you can see the breakdown in gender demographics that were represented on the survey. So what changed with the methodology? So the survey was offered in different ways, and Quality also provided the network with a universal tracking sheet. The tracking sheet had each individual case manager, support coordinator, and therapist note their entire caseload, how that individual, if they desired to, wanted to take the survey, whether it was by email, telephone, ground mail, or in person, and also the result of that. So once they filled that out, they then gave those sheets to Quality, and Quality, we reviewed the information, and if individuals wanted a phone call, we did that. If they wanted the information emailed, we delivered that. We also ground mailed over 250 surveys, so a lot of people wanted them mailed to them as well, and we were able to provide that, and then the Quality department would then go in and tally up into the SurveyMonkey link, and then tally up and put those answers within there. So part of the reason we wanted to do this was to enhance quality. So we wanted to ensure that the questions that we were asking actually fit what our larger auditing bodies asked us for. So we all worked together and utilized questions from SAMHSA and AHQR, which is the Agency for Healthcare Research and Quality, to come up with these good questions, or more evidence and research-based questions, so that we can yield different results. We also held ourselves to a higher standard than some of our surrounding areas. We adhere to an 80% pass rate, and the highest that we've seen around us for organizations that look like ours was 70%. And we also only tally strongly agree and agree responses to produce that pass rate. So, excuse me. So any question that falls below that 80% pass rate, we must follow up with the responsible department, or the department that has the most responsibility within that indicator, and Quality works with that department to come up with a plan to improve that indicator going forward. This year, we did have one question that fell below the indicator, and that question was around psychiatric services. So when asking individuals, were they able to see a psychiatrist when they wanted to, we got 733 individuals out of the 1,091 say that they strongly agreed that they were able to see someone when they wanted to, or they agreed when they were able to see somebody when they wanted to. So what that yielded for us was a 61.9% fail rate, or not pass rate. I also thought that it was important to note, however, that meant 24.38% individuals did say that they neither agreed or disagreed. So because we hold ourselves to this rate where we only calculate strongly agree or agree to our questions, it meant that we essentially didn't pass this. But this 24.38% could have been individuals who may not participate in this service. So individuals who may fall in a different population who may not need psychiatric services also had to answer the same question. And one of the changes, as we'll see in a couple of slides that we're making, is to put a does not apply option, which we didn't have this year, but we learned from executing the survey in this manner. So only 8.43% responded disagree and strongly disagree. And I think if we look at those numbers, the latter of the numbers, the 24.38% and the 8.43%, it gives us a different picture than the 61.9%, just seeing that we didn't meet the threshold. I think there's reasons why, and people could have answered those questions differently if we would have had a different answer that people could have selected. So, however, quality is working with the Office of the Medical Director right now to identify ways that our network can improve this indicator, and that will be evidenced in this upcoming year's survey. So what did we learn? So some of the network demographics that we were able to see from this is 165 of the respondents this year were new to the network. So that was wonderful that we got the voice of persons who hadn't been experienced to be represented in the survey, and 779 were returning participants, and the remainder, I think is 151, they chose not to say whether they were new or returning. The age demographics I thought were good as well. We got some individuals who responded who were under the age of 18, several, and the majority, of course, who were over the age of 18, and 21 individuals who chose not to say. This last demographic I thought was important to note, that 58 individuals chose that they didn't want to express their gender, or that they chose other. And that, I think, is important because going forward, some of the things that we're changing is providing additional gender identity options. So having those in alignment with the CCBHC requirements, and as I noted before, including that does not apply option, so we can get more real data as it pertains to question number 7. If individuals wanted to receive psychiatric services, maybe that isn't something that they participate in, but they were kind of forced to answer that question if you went through the survey. And then increasing the amount of population specific questions. So working with experts in our field to make sure that the survey is optimal and that it represents all populations more thoroughly. Because some of the things that we saw and some of the results that we saw this year certainly let us know that we can expand on that. And one of those things is including that does not apply option. And that is all I have, and I thank you very much for your time.
Thank you, Ambrosia.
Absolutely.
Good presentation. Any board members with questions or comments? Kathy, go ahead.
Thank you. Ambrosia, if you go back to the slide that says psychiatric service indicator. First of all, thank you. I should have started out with thank you for the report. It's very, very interesting, and I'm glad that we have starting some of these types of reports. And I'm going to, I think, unless I'm doing something wrong, we're going to improve that score, because when I divide 733 by 1091, I get 67.19%.
Oh,
okay.
So I think maybe just a typo or something, but
yeah, it must be a typo. My apologies.
Well, thank you, Kathy. That made us look better.
There you go. That was all, Mr. Chair. Thank you.
Thanks, Kathy. Cindy, change that on the presentation quick. Any other board members with questions or comments?
I have a question, Phil.
Go ahead, Ryan.
Thank you for the presentation. Question is what a tremendous improvement we had from last year when we were paper only to now all these other ways to reach out and have more feedback. What are we doing and what can we do to gather more information from others? I mean, is there any kind of selection bias in that certain people say, well, I want to, take advantage of the survey and do the survey? How can we encourage the survey? Are we looking into that? What are we doing in that front?
Absolutely. So going forward, encouraging people to participate in kind of the person served survey kind of training. And that would include maybe team members if they are having trouble with a certain section of their caseload wanting to participate in services, then giving the quality department a call and seeing how different ways we can encourage those individuals. Or if they don't want to have the information presented to their primary care provider, making sure that they know that the option for the quality department to be contacted directly is also an option. But just giving people language to encourage them to participate. So saying things like you're making a difference, because they are, you're making a difference in how we deliver services. Your voice matters, because it does, to individuals, and just the way we kind of encourage people to take the survey going forward, I think will make a difference in how many people we are able to yield to engage in the survey.
One more follow-up question. The survey, is it anonymous? And do the
Indeed.
participants know it's anonymous?
Indeed.
Okay.
Unless they choose to be contacted by our ombudsperson, then they put their contact information down there, and that's only shared with the ombudsperson. And this year, we have 42 individuals who chose to be contacted. Each one of those persons were contacted and follow-up was made.
Thank you.
You are most welcome.
Thanks, Ryan. Dave has his hand up.
Just to support what Ambrosia was saying too, we continue to look at other technology upgrades that will help us collect that type of information. And the board did approve our contract for Happy or Not, and we are using that. We've had to go through some tweaks and changes with that. So once we get some good historical accurate data, we'll be sharing that with board members as well.
Dave, Happy or Not, that's the kiosks that you have?
Right, and it's also on our websites, the
Okay.
smiley faces or frowny faces, red or green.
Thanks.
Thanks, Linda. Any other board members with questions or comments for any piece of the presentation?
And I'd like to thank Dave for allowing us to highlight the experts in the field. I mean, you know, quality, I'm chief quality officer, but it doesn't mean I know all of the details of everything. You know, you do your best, but so it was really helpful. And I love to help spotlight some of the experts. So thank you, Dave, for letting us do that.
Anytime.
Yes, Cindy, thank you to you and your team. We appreciate the presentation. And if we have questions, we know where to go. All right, seeing and hearing no other questions or comments from board members, we have a motion and support to receive and file. All in favor signify by saying aye.
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 All opposed? The presentation is received and filed. Thank you all. Next is item 8B, CEO report. I'll take a motion to receive and file before Dave gets going.
So moved, Schmidt.
Motion from
Support,
Steve,
Phillips.
support from Lori. Dave, go ahead.
Oh, I thought I'd have Laura and Ambrosia present my report tonight too. And so, just so I don't forget as well, I'm very much in favor of, you know, getting as much information in front of the board members as possible. We started these departmental reports, which I think are very helpful. They help me as well. We did receive an email from a board member who may want to speak up or not about provider feedback at the board meetings as well. So Christina, our Chief Network Officer, will be reaching out to our provider system to see if they have information. You know, we hear from Sean at CEO frequently, but to get their feedback too about how they're dealing with the pandemic and any other issues. Lori?
Well, I'm not saying who the board member was, but I think I think it's important because we deal with so many different agencies in so many different directions that it's great that we hear from CEO. But again, with all the trials and tribulations over the last year, especially, that it would be important. What are the ABA therapists doing? What are the ABA centers doing? What are the other organizations? Have them, invite them to come and tell us what are they doing and what's your plans moving, forward a little bit too. Because, nobody is really meeting in masks. And I know, you know, my son sits and does Zoom for a few hours a day, which is also on a small basis. But I just think it would be good for all the board members. And as a parent, I kind of have ideas on some things going on, but I think it's important that the other board members too know, and the community knows that this is what's happening. And I think I'd like to hear some accountability from the other places too, besides CEO, on a monthly basis.
Right. So we will be opening that door. I also, as far as on the communication front, I informed the leadership team that if they had information that they would like to share with the board in between their departmental reports, that they could share that with me and I could include it in my report. And I have an example of that in my report. Selena?
I think that it's not just about getting our providers to come and tell us what they're doing about the COVID situation, but we have some providers that are really thinking outside the box and really doing some great new things out there. And so by sharing them with us, it may also have other providers listening in and starting to think about how do they step up their program. So I do know that Christina did send the letter out, and it was about getting people to come in and highlight their organization, give us feedback on what is going right, what is going wrong, you know, where do they need help from us, you know, where could they like partner up with somebody else that maybe their struggles are with. And so that did go out this morning, and you know, we did receive it. But I think this, you know, I think it's time for them to showcase how resilient they've been and how they can continue. We got some phenomenal providers out there. And so we really, you know, it'd be great to hear from them also.
Yes. So thank you, Lori. Just before this meeting, it might have been yesterday, but I received the update from Alan Bolter that the Michigan Senate introduced Senate Bill 114, which would provide $1.3 billion gross, $560 million from the general fund into this fiscal year's supplemental appropriations. Quick summary, $227 million to extend the direct care worker wage increase, the $2 per hour, to $2.25 per hour until June 30th, applicable to the same eligibility groups as before. 110 million for vaccine distribution, 184 for COVID testing, 8 million in funding for the mental health block grant, and 17.4 million for the substance use disorder block grant, which would help fill part of the hole that they caused with the substance use funding cuts that we have shared with the board previously. Does not fill that hole, but it offsets some of the loss. Let's see, the bill was referred to the Senate Appropriations Committee. So it's still unclear at this time how the two chambers will reconcile some of the differences and go on from there. So I'll continue to provide updates. Believe I shared with the board the unenrolled proposal at the PIHP level. So the 10 PIHPs came together. Actually, we had a conversation that goes way back. When the 298 pilots came off the table, we recognized the unenrolled population kind of was highlighted when they were doing the 298 pilots as, what are we going to do with these unenrolled people? And they were trying to kind of patch that up real quick, and then 298 went away. So we put together a white paper that has been gone through some modifications, and it's been shared with the Community Mental Health Association and some folks at the department. It is being actively followed up on. So we're going to have another meeting with some of the, like an ad hoc committee of the CMH Association. Brad Casemore and I have been the PIHP points on this project. So as things develop, start to go forward, I'll keep the board updated. Also with the association, they pulled together, Bob Sheehan and Alan, the Metro Detroit Futuring discussion. That was on, I'm sorry. I pulled up the date of our next meeting instead of the last meeting. I'm like, that's not it. But we had one meeting. It was Detroit, Wayne, and Oakland. I'm sorry, Detroit, Oakland, and Macomb, or Wayne, Oakland, and Macomb. Along with some of the big providers that kind of cross county borders. And Nick, you had a question?
Oh, I just wanted to, at the end of your presentation, but I can do it now, just on the budget issue that you were talking about.
Okay.
So I was aware.
Come back. So anyway, it was a very good meeting, lively discussion about you know, issues specific to the Southeast region. We did agree as a group that we thought there would be benefit to continuing those discussions. So we do have a follow-up meeting scheduled for the 19th of this month. I also volunteered to be on the tiered rate work group. This is an issue kind of, I was going to say near and dear, but the state's working on the rate structure for the license settings. So the personal care and community living supports, and then how would they assess and determine the appropriate rates for various levels within the license settings. I've worked on this. I've been on statewide work groups and things before. So it's a very important topic to us as we continue to look at our residential services. On that note as well, we have had a couple of meetings. I've met with Mork, and we do have a transition teams in place. So we are following up on bringing those residential contracts directly under us. And we'll continue to provide updates to the board on that. And again, when I reached out to the leadership team meeting, Dr. Serpa took me up on that. And she asked that I share an update on our preventative care guidelines that she has been working on for a long time now. This one is early detection of colorectal cancer. This is the third topic in a series. So far, she's worked on topics of importance such as vaccination recommendations in high-risk populations and breast cancer prevention in both male and female populations. The objective of the series is to help create awareness in the community and within our network of providers about best preventative care practices, assist network providers in understanding the important role they play in the integration of care, and to help educate the people we serve and the community at large on the importance of preventative care. We will continue to add more topics to the series as part of our initiative periodically. And Dr. Serpa will work with the leadership team in presenting this new topic to the network providers. We're also moving forward with the implementation of the consumer medication coordination pilot at the North Clinic. That's our Genoa contract. We are very excited and look forward to seeing the positive impact it'll have on improving care coordination. So that was for the update from Dr. Serpa. A reminder, we do have the Metro Region Dinner next week. That's Thursday the 18th from 6 p.m. until around 8:30 p.m. We'll probably touch on some of that futuring discussion, even though it was not a specific point on the agenda, but it'll be a pretty open meeting. So I'm happy to take questions, Nick.
It wasn't a question, just a quick comment, because you were talking about budgetary issues. Just want to let the board know that I got notice today. The governor's budget will be presented to the legislature tomorrow. I should get a briefing on it early in the morning, but it should be available online. And I suspect Alan will have additional information to give you as well.
Thank you. Ryan?
I just want to circle back to the discussion Lori and Selena brought up with, well, first of all, I personally love the department head high-level meetings. Quality did a fantastic job today. It just really helps inform all of us. Well, it informs me anyway, and it's really, and I guess other board members, I know I personally really enjoy it, learn a lot from it. Every department that's presented, always learn a tremendous amount, and I think we'd learn even more from the providers. I think that's a great idea. Dave, or the rest of the board, do you need a motion to invite these providers to provide some kind of presentation? If not, then we're good. If so, happy to make a motion.
Nope, we can just add them to the agenda. Perks of being chair and vice chair, I guess.
All right.
You approve the agenda, so there would be that.
We'll get them on the agenda, Ryan. Tony, go ahead.
Sounds good. Thanks, Phil.
I also like the idea Lori brought up to bring supply providers in. Thank you very much, Lori.
Yep, now that we all know that Lori did it. Thank you, Lori. Any other board members with questions, comments for Dave or in general?
I have a comment for the board and Dave. This week is the association conference, and today a workshop. I think Dave was in it too. There was an excellent workshop on CCBHC, and I want Dave to tell us what that stands for. I can roll it off my tongue, but I forget what it stands for. But it's a revolutionary kind of, the counties that reported are people who were in the project for the last 3 years. For people who were on the board 3 years ago, you might remember that we applied to become one, but our application wasn't selected. And so we're very excited to be in it now. But what all 4 counties that or agencies that presented today talked about was that it's an incredible opportunity for the communities that we represent and for boards to have big input. So I'm just saying that hopefully that's down the road, that we get, more information, and that we figure out what that vehicle will be for kind of molding what our effort in it will look like. What did you think of those presentations, Dave, today?
Very, very good. Little anxiety provoking.
Right.
I was a little more stressed than usual all day long, but thank you, Linda, for reminding me. The CCBHC is a certified community behavioral health clinic. We did get the multi-year SAMHSA grant for that. Then the state of Michigan became a demonstration state after that. In talking with the folks at the department, a lot of energy behind this and getting the state demonstration project stood up by October 1st of this year, if not sooner. It does allow us to provide services to people who do not live in Macomb County, who might have private insurance, but would benefit from things like our assertive community treatment programs. It allows us that flexibility where we can see most people who would be presenting at our front door. What we've been talking about internally now, Jim Losey helped do the actual our proposal response. And both Jim and I, when we started doing the budget, we were considering the 3.4 million as like another funding stream, another bucket, like Medicaid, Medicare, general fund. And right at the end, when we were working on the budget forms, we realized that's not how this is set up. And then we did the budget like a staffing grant, and we said, okay, we would need these people in these positions in order to provide this service. Then again, we keep learning and talking to more people. That's really not it either. It's not a program. It's not a funding source, anything like that. Those funds allow us now to be a CCBHC. So pretty much from this point forward, we are operating as an integrated health clinic. So everybody who comes in will be offered that service. We will be working with them closely. We will be assessing, doing some initial outcome measures. And then for the people that, are open to that, they'll continue to work with us in that area. And that was a big part, Linda, of what they were commenting on this morning, was the importance of the data and showing those outcomes. So now 2, 3, 4 years down the road, you can show that you've had an impact on smoking cessation or weight loss, some of these key indicators that are being tracked. And it was really exciting and energizing to the staff working in those areas. So we're early on still. It was approved May 21st, but we had a 4-month window there to get things situated. So the first year is abbreviated. It's stressful. We have a great team working on it, but we're doing a reset right now. And like I said, we will be just open to everybody and providing this as kind of our standard operating procedures from this point forward. So it's fun. We will be working with our staff. We will be providing additional supports. I've met with Crystal and her team about the front door services as well. Chanel from customer service will be joining our CCBHC discussions so that we have a consistent message for new people coming in. We are also reaching out to people that we are already providing services to look at getting them into this that system as well. So there's a lot of data reporting and tracking and monitoring and various health indicators, and that's one of the foundation points of this project. One of the people this morning, they said they had like over 12,000 people come in, but of that they had about 5,500 who actually completed all of the ongoing data set measures. And that's what gets counted towards the grant. So we're working on this daily, and there's a lot of time and effort going into it, but it's the future now. I think we're definitely on the right path, and we're in a really unique spot statewide. The other regions, they're talking about a funding methodology that would come down through the PIHPs and then go to a CCBHC site within their region. That's easy for us because we're the one-stop shop. So when they look across Michigan, Macomb is very uniquely situated, I think, to really take advantage of these dollars to help us do the infrastructure changes that are needed.
Right. Dave, does it require a citizens advisory, some kind of a board or advisory on the CCHB, specifically?
We have to have a CAC, and our CAC did agree to serve in that function. So they're
Okay.
serving a dual role. And I'm meeting with them next week. And I'll provide this update to them.
Great, thanks. Thanks for that update.
Thank you.
Anyone else? Questions, comments for Dave? All right, seeing and hearing none, we had a motion and support to receive the report. All in favor signify by saying aye.
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 All opposed? The report is received and filed. Reminder, our full board meeting is Wednesday, February 24th at 6 o'clock. Happy Valentine's Day and President's
Aw.
Day and every other holiday that's coming up. Dana's weekend getaway, I don't know.
Right.
Yes.
Sorry, Dana. Next, we will go to hearing of the public. Anybody from the public wishing to speak? Again, you have 5 minutes. Give us your name and address. It can be about any item. Hearing of the public going once. Make sure you unmute yourself. Hearing of the public going twice. Third and final call for hearing of the public. All right, hearing and seeing none, we will close the hearing of the public and I will take a motion to adjourn.
So moved.
Don't move.
Motion